Hi, I'm Dr. Jared Gardner, and I'm here today with the awesome dermatology residents from Emory University, and they invited me to come and give case presentations and unknowns after I did grand rounds with them today. And so I shared some digital slides here, and we'll record this and make these slides available. They're actually available right now on Kiko XP, although I have the comments disabled so they could be used as unknowns. So, and now I'll give you guys a chance to tell me what you think, and then we'll discuss, okay? So let's see here. This is case one. It's a 60-year-old woman with a nodule on the elbow. And let's full screen that. All right, so what did you guys think about this case? Does anyone have any ideas for what it might be? And again, don't be shy.
Rheumatoid nodule?
Rheumatoid nodule. Very good. And you can see we're down in the subcutis. You know how we know we're in the subcutis? You can see a little fat here, but anytime you got a full nodule that basically has no skin with it and no muscle with it, you're probably in the subcutis. I mean, anything that's taken out like in office, that is. I mean, a general surgeon can go pluck a little piece of something out of the retroperitoneum, of course, but as a general rule in Dermpath, when you see a relatively circumscribed nodule with nothing attached to it, or with a little fibroadipose tissue, you are probably at the level of subcutis or maybe fascia. And that's what we've got here. There's a big cystic space in the middle. But more interesting than that is this stuff out here around the outside, which you guys recognize right away as rheumatoid nodule. So rheumatoid nodules obviously develop in patients with rheumatoid arthritis. Some patients get them, some don't. Some get multiple. They can occasionally be like in the lungs or other organ sites, although I don't know that I've ever actually seen a case of that. But what they are is they're granulomas, right? They are palisaded necrobiotic granulomas. So that's the general pattern that we're dealing with here, is the palisaded necrobiotic granuloma pattern. You got histiocytes forming this palisaded lined up kind of rim around a central zone of necrobiosis. So what is necrobiosis? Well, I think it's actually kind of like a fancy word for dead collagen, basically, okay? The idea is that is a kind of a collagen-rich central space that has minimal or few nuclei there. So the fibroblasts make the collagen, and then as the central area dies, the fibroblasts go away, and the collagen proteins are left behind. And oftentimes that goes hand in hand with some other substances, okay? In this case, the general thing that's left behind here is fibrin. So these granulomas tend to have a very fibrin-rich, or what we sometimes say fibrinoid necrosis. It's kind of dead collagen mixed with a bunch of fibrin. So it gives them this very bright red, kind of brick red almost appearance. So these are classic examples of rheumatoid nodule. They are red granulomas. They usually have a predominantly red color in them, okay? And let's go over to the side here and look at these cells. These are bland histiocytes. They kind of have oval to round nuclei and abundant cytoplasm, and they're kind of packed close together to make this nice row here. So what's one bad thing, a malignant thing, that can mimic rheumatoid nodule? Does anyone know?
Epithelioid sarcoma.
Very good. Epithelioid sarcoma. So the best way to sort out, I mean, they're the first step in sorting out epithelioid sarcoma from rheumatoid nodule. At low power, they can look similar. Some epithelioid sarcomas make these palisaded arrangements, but in the middle, they have like true tumor cell necrosis rather than this fibrinoid necrosis. So once you go and zoom into higher power, right away, you'll be like, oh, the cells look really ugly and bad for a epithelioid sarcoma. In rheumatoid nodule, they have very bland nuclei. Now, there are mitoses. That is very common, I feel like. I see mitoses in rheumatoid nodule like essentially always. It's a normal finding to me. But the cells, the cytologic features are much more ugly in epithelioid sarcoma. And once you've seen some examples, you'll recognize that most of the time it's pretty easy to tell they look a lot uglier than these. If you have any doubt, you could do some stains. Keratin and EMA will stain the vast majority of epithelioid sarcoma, and usually epithelioid sarcoma has loss of nuclear INI1 expression, or SMARCB1, SMARCB1. So those can all be useful tools if you have any doubt. If I have any doubt, I just do the stain. It's a real cheap way to rule out something that's very rare but very, very bad. The other thing I'll point out is that a lot of times I see some scattered neutrophils and nuclear dust in the setting of rheumatoid nodule, and usually we're taught that granulomas with neutrophils equals infection. But I feel like this is a finding that I see in rheumatoid nodules really often, actually. It's a very common finding. I have rarely seen examples of infectious granuloma, like atypical mycobacteria, that had a kind of vaguely rheumatoid nodule pattern. So if there is a concern for infection, you could do stains, but I don't always routinely do that. It depends on the setting. So this is a really nice example. The palisading is not always going to look this good, but this is just like amazing, right? Look at that. Red granuloma, that's like the picture to burn in your mind of rheumatoid nodule. And they do tend to arise down in the subcutis or near the fascia, but you can see them next to joints as well. Like this one's olecranon area, like around the olecranon bursa. The center, sometimes the fibrinoid necrosis can kind of break down and give you this pseudocystic appearance after processing. That central fibrinoid necrosis falls out and goes away. So that's one of the important members of the palisaded necrobiotic granuloma pattern that we see in Dermpath. And also, even though these do tend to be deep, I see them in the dermis often. I've got multiple examples in my teaching sets of rheumatoid nodule that's in the dermis as well. So don't let it concern you. If you see it in the dermis, it could still be rheumatoid nodule. And sometimes they're huge like that. Sometimes they're little like this. And they do tend to be like multiple granulomas clumped together. Like this one, as you can see, many different small, medium, and large granulomas all aggregated together to form the whole nodule. All right, so rheumatoid nodule. Any questions? Okay, well, we'll move on to the next case. Let me hide the bookmark bar here to give a little more room on the screen. Okay, case 2. I'm working on Wi-Fi here in an extra spare bedroom in my house, so it's not quite as fast as my usual setup. So here we have a 12-year-old girl with a nodule on the dorsal finger. Whoa, that was a little faster zoom than I wanted. You can see we're on acral skin. So what's the, does anyone want to take this one and tell me what they think?
I see a palisaded granuloma again, but more of a blue center. So it's more like a granuloma annulare.
Very good. Yeah, this is a perfect example, and I like this one because it's like so strikingly palisaded, just like that rheumatoid nodule. As you all know, having done a lot of unknown sessions, I'm sure, with Dr. Parker and the other faculty at Emory, you've probably seen lots of granuloma annulare, and if you have, you'll recognize they really run a wide range. They can go from being very subtle interstitial pattern where they trickle between collagen, all the way up to ones that are very well-formed palisades around a beautiful mucin-rich core of necrobiosis. And this is what I'm talking about. You can still see the collagen bundles here. And how do you know collagen's dead or alive? Well, the collagen's always, I guess, dead, so to speak, right? I mean, it's an extracellular protein. It's made by fibroblasts and pushed out into the extracellular space and fills that space up with bundles. The key here is that you have collagen bundles, and they sometimes get kind of smudgy, degenerated look, but also they don't have corresponding fibroblasts. So it's not per se that the collagen has now died. It does begin to degenerate over time, but really the key to recognizing that necrobiotic appearance is the paucity of fibroblasts. There should normally be scattered fibroblasts in the dermis, and as you get well-developed necrobiosis, you begin to lose those fibroblasts. You also begin to get blue mucin or myxoid, depending if you're a pathologist. You often will say blue stuff like this is myxoid. If you're a dermatologist, there's a tendency to say mucin. But what we mean is glycosaminoglycans, hyaluronic acid, ground substance, okay? And that you often have that in granuloma annulare, although I would not say it's a requirement. I certainly see cases of GA that have minimal mucin in them, okay? And let's look at the cells around the outside here. So again, bland histiocytes, kind of oval to spindle nuclei. Oh, I forgot to enlarge it, I'm sorry. How about that? There we go. And they kind of palisade around the outside, just like we saw in rheumatoid nodule. But here there's the bluish center. So the blue mucin is a pretty good clue that you're dealing with granuloma annulare. Although sometimes I've seen cases of GA that had fibrin in them. I believe, if I recall, the rule, so to speak, is that you can have a granuloma annulare that has red fibrin in it, but usually you don't see much blue mucin in rheumatoid nodule. But I'm not totally sure that rule always works. And to me, the more important thing is if I see a palisaded necrobiotic granuloma And I'm not sure if it's a deep, because this is an example kind of it's almost deep granuloma annulare. It's in the dermis, but it goes way down, and you can see there's plenty of it here at the deep dermis pushing down into the subcutis. So when there's a lot of subcutaneous involvement, we usually call that deep granuloma annulare. And those tend to present as one or multiple nodules, often on the lower extremities of kids. Sometimes you can see them on the hands or other sites too. But they do tend to be deeper, and because of that, they can sometimes mimic a neoplastic process. So if there's any doubt, though, between rheumatoid nodule and granuloma annulare, I just put in my report palisaded necrobiotic granuloma and a comment that this could be granuloma annulare or rheumatoid nodule, and then the treating physician can inquire from the patient, do you have a history of rheumatoid arthritis, do you have joint pain? If they want, they can do some serology, but it's pretty easy to pursue further to see if the person has rheumatoid arthritis or not. And if any doubt, I'd rather have that on their radar, even if it ends up not being what it is. So that way they know, okay? And yes, so what I was gonna say though is at the periphery, what happens is you see nice palisading right around the necrobiosis, but also as you get out further, there's almost always, I would say most granuloma annulare have this, they have a tendency for the histiocytes to trickle in between collagen bundles like this. And the appearance that gives is the appearance of collagen trapping. So I often can trick my residents into thinking that if I show them the right part of the slide, and yes, I'm kind of cruel sometimes, I guess, but I'll trick them into thinking that a GA is a dermatofibroma or vice versa, because at the periphery of DF, dermatofibroma, and the periphery of granuloma annulare, you have a similar pattern of this fibrohistiocytic, spindly histiocyte look cells that are wrapping around and trickling in between collagen bundles. And another thing that does that is blue nevus. So when blue nevi lose their pigment, they look a lot like dermatofibroma because they trickle between collagen at the edge, and they can have some similarity to this is what we call the interstitial pattern of granuloma annulare. So the interstitial pattern of GA, it's not like some different disease, it's just a different pattern microscopically of GA. When GA is completely composed of trickling histiocytes in between the collagen, like if all of the GA looked like this, then we could say interstitial GA. But what I find much more often is that you just see interstitial areas at the edge of more well-formed classic granuloma annulare. Sorry, it's a little laggy here. There we go. And again, you can see really nice necrobiotic collagen, blue mucin in the background, and the histiocytes around the edge. So that's granuloma annulare. Sometimes there's an inflammatory response with it. Sometimes you can see scattered eosinophils. That's a relatively common finding. And what was there any other point I was going to make? Oh, one thing you don't usually see is you don't see well-formed sarcoidal type granulomas. Usually the granulomas in GA are either that ill-defined kind of trickly interstitial pattern or very nicely necrobiotic palisaded granulomas with mucin in the center, but you don't usually see like tight sarcoidosis type granulomas. So if I see that, that usually steers me away from GA and makes me think of other types of granulomatous disease like sarcoid or like infection. Okay, any questions? Okay, excellent. Let's go back here to case 3. So this is a 65-year-old woman with an annular plaque on the left side. Okay, so here we go. Sorry, this one's got a little bit of wrinkling in the tissue, but I think it's a pretty nice example and a really good learning lesson. So 65-year-old woman, left side. So is anyone here? I think this piece is the better piece to go with. Anyone have ideas for what this might be?
Interstitial GA.
That really looks like it, right? It's annular, it's on the trunk in this case. And I just showed you 2 palisaded granulomatous things. And here we've got cells that are trickling between the collagen, just like, in fact, I didn't put it in there, but what this actually came in as was rule out GA. That's what it was. I just am intuiting or inferring that there were annular lesions, but it was sent in as rule out GA. But let me point something out. As we go in closer, boy, the cells do. This is such a good case because it shows how easily you could get burned. Something about the cells to me looked a little weird cytologically. I mean, sure, they kind of histiocytoid looking, but as I looked around, I saw little tiny things like this little tiny circles that have blue stuff in them. And let me see if I can find the area again. Ah, there we go. There are areas where the cells look more like very round nuclei, and in some areas they kind of started to clump together or string along in a linear kind of fashion like this. If I showed you this area, oh, and then there are mitoses, although again, mitoses in GA, no problem, I see that all the time. Does this, if I told you, okay, it's not GA, but the reason I'm showing this is because it would be so easy to mistake this for GA, especially because it was sent in with a clinical from a dermatologist of rule out GA. But what if I just showed you this picture? What other things would be in your differential? Anyone?
Metastatic breast carcinoma?
Yes, indeed. So let's see if I can find the slide that shows, and this is the site of keratin 7. Blazing positive. You can see it staining the eccrine coils here and strongly staining these tumor cells, which look quite histiocytoid, I admit. And I think that's the kind of treacherous pitfall. The single filing here is very easy to see, right? But it can kind of have an overlapping appearance with that trickly look that you see in interstitial GA. One thing I'd point out is that usually interstitial, like I mentioned earlier, interstitial granuloma annulare tends to be a pattern I just see focally at the edge of more well-formed granuloma annulare, and it's quite rare in my experience to have like a big sample of skin where all I see is interstitial pattern GA without any necrobiotic palisading mucin-filled granulomas. So that's one clue here. So we've got this huge slab of skin and all this trickling interstitial pattern, but no actual like good necrobiotic palisading pattern to go with it, which is what I would expect in a GA with this big a sample. I would expect I'd find some areas usually. But here, thankfully, and I can't remember exactly what it was, but some area of the slide reminded me of breast cancer, and I thought, let's do a keratin, and it was positive. And then when I talked to the treating physician, turns out the patient actually had known stage 4 breast cancer, but they had kind of forgotten to mention that, and they really didn't think that it looked like breast cancer. And by left side, what we're really dealing with is the area near the mastectomy site from where the breast cancer had been removed a few years ago. So side, when I always joke when people say side, oh, is it the left side or okay, I guess it's not the right side. Because I mean, what's that mean? Like half of your body? I know that what people mean is flank instead of side, but sometimes precision with our words regarding the anatomic site can actually be pretty meaningful. And this is why I hope you all know this already, is encourage taking photographs. I cannot tell you how many times I've looked at the description, I've looked at the slide, I've thought, oh, I think this is good. And then I look at the clinical photograph and I'm like, backspace all the stuff I just wrote in my report because there's no way it can be what I thought it was. All it took was one look at a clinical photo. And what I had envisioned in my mind from the clinical description was very, very different from what I was seeing. And it wasn't that the description was necessarily bad. It's just that the whole picture worth 1,000 words thing is so very true. And it's especially applicable to dermatology and dermatopathology. And also the clinical history, really important. So this is just hits home. I know how very busy you guys are in clinic as dermatologists. And I know that sometimes there's not the availability to always mention everything that's relevant. But knowing if a patient has a cancer history, especially if they have a bad tumor like a thick melanoma, or they have a known metastatic cancer, that can be really, really important for us to know if you happen to have access to that information. And I realize that as dermatologists, depending on the clinic setting you go into, sometimes you are not given that information. I've seen many times once I've talked to the dermatologist that they were as shocked as I was because the patient had been treated in another institution for their cancer and then just came to the derm because of a mole or a rash or a whatever thing that they thought was a nothing and didn't realize it was something that actually related to their previous cancer. So I always want to know if that patient has a bad cancer, a metastatic cancer, if they've had radiation or chemo. That can be hugely important to know. In fact, it's a lecture for another time, but I recommend all dermatologists to include on their intake forms the question, not just do you have a history of cancer, have you ever received radiation therapy? Because radiation therapy can obviously predispose people to certain things like angiosarcoma, and there have been plenty of times where knowing that history made a difference. So here was, I think, a very treacherous example of a metastatic or local recurrence. I never did quite figure out if this was skin met or direct. Oh, I'm sorry, I take that back. I think this was more likely a skin met because of the pattern of growth, right? You can see it's really confined to the skin here rather than direct extension. So yeah, and this was one where we really could have made a big mistake here and missed this, but thankfully we sorted it out in time. So that was a metastatic breast carcinoma mimicking both microscopically and clinically mimicking granuloma annulare. A 75-year-old man with an ulcerated erythematous nodule on the scalp. And let's see, I included an extra image here. This is the CD10 stain, blazing positive on CD10. Let's see here about making this bigger. All right, again, apologies for the wrinkles, but this is such a very valuable case for teaching that occasionally I overlook when that kind of stuff happens. Histotechs are amazing, but sometimes the tissue does not cooperate. So we got this ulcerated nodule here, and the dermis is filled with cells. And when we go closer to look at what this sheet of cells looks like cytologically, all right, these cells have a very unique appearance. If you had to use a word, what word would you use to describe this cytologic pattern or appearance to these cells?
Crescent.
Yeah, the nuclei look like little crescent shape, right? And they've got this blob of very dense pink. You know what I mean by dense? Dense means like it looks like the cytoplasm looks hard. And I know that sounds kind of silly. Like in pathology, we get really used to talking with these words that make sense to us, but like, what do you mean hard cytoplasm? It looks like it's so packed full of pink stuff that's very dense and homogeneous, kind of like the pink color of like keratinocytes. Their cytoplasm is kind of what I'd call hard or dense. It's packed full of keratin, as opposed to loose cytoplasm, which would be like what xanthomatous cells would have, or cells that have kind of loose, fluffy looking cytoplasm. But these have this blob of really dense pink stuff. And then it's so big that it's pushing the nucleus out of the way. It's pushing the nucleus out to the peripheral edge of the cell. So the other anyone else? There's two possible answers you could use for this that I feel like are very similar pattern-wise for this blob that's made the nucleus become eccentric.
Rhabdoid or plasmacytoid.
There you go. Yeah, and is that a pathologist who said that or a derm resident?
I'm the fellow.
Oh, okay, awesome. Hey, cool. Yeah, that's exactly. And to me, I'm into soft tissue, so I like the word rhabdoid. But rhabdoid and plasmacytoid, I feel like there may be some subtle difference between them. But to me, I feel like they're very similar terms where they mean that the nucleus is eccentric, just like a plasma cell. It's pushed to the side. And you, particularly when you see like a blob of pink, dense pink stuff, a lot of times people use the word rhabdoid when the nucleus is pushed to the side and it's got a blob of pink. So these are kind of rhabdoid-looking cells. Diffuse sheet filling the dermis. So it's kind of like, packed all the way up against the epidermis. The epidermis is ulcerated away. CD10 is positive. So what's your diagnosis or differential diagnosis here? Because I only gave you one stain, and as you probably figured out, more stains were done, which I have not informed you about. Well, let me ask you this. What do you think that this case might have been misdiagnosed as?
AFX.
Yes. So with the CD10 expression, CD10 has been in the past described as a stain that's helpful for the diagnosis of atypical fibroxanthoma, or the very closely related, or in my opinion, I think they're just on a spectrum, pleomorphic dermal sarcoma, which is basically the term we give for AFX when it invades down into the subcutis and has the potential for more aggressive behavior. Okay? So yes, this case was, understandably, diagnosed as an unusual example, they thought, because of the cytology, but they thought it fit best for the AFX/pleomorphic dermal sarcoma spectrum. They had done, I think, pankeratin, S100, and what else did they had done that pankeratin, S100, and I think P40 or P63, and they were all negative. So reasonable to understand that they've ruled out, the SLAM differential, as you guys know, right? You rule out your spindled squame and leiomyosarcomas, although in my opinion, that doesn't really come into my differential for AFX very often because it usually looks different. Angiosarcoma occasionally can be solid. Certainly you could potentially see an angiosarcoma look kind of like this. And I can't remember, maybe they had done a vascular marker. This was years ago. And also melanoma, okay? So they had done the major stains there. But, okay, who the fellow, what's your name, dear fellow? I apologize.
Oh, Adam
Oh,
Perkin.
Adam. Yeah, Adam Perkin. I forgot that you were a fellow already. Awesome, man. Well, good work. All right, Adam. Well, what would you do with this case? What's in your differential, or what additional stains would you like to do to solve this?
With the cytomorphology can consider, plasmacytoma due to CD138. Rhabdomyosarcoma can get a desmond SMA as well. And then, like proximal type epithelioid sarcomas can exhibit the same type of morphology. You can consider INI1 or even BRG1.
Fantastic differential. Very, very good. And yes, I think your point about plasma cell myeloma is outstanding. It is often not on people's radar. And because it is a heme thing, it can look a lot like when it gets into the skin, it often doesn't look like regular plasma cells. I've seen a fair number of cases. In my former job, we had a lot of patients with myeloma. And so we would see cases where it got in the skin, and it often looked kind of like leukemia cutis, real ugly, but it can have a wide range of features. And the hematopathologists that I worked with would show me cases again and again that did not look at all like what I expected a myeloma would look like. Sometimes very pleomorphic, sometimes almost spindly, super scary. So it's really quick on my differential to think of doing plasma cell markers, and also to remember that plasma cells and myeloma don't express CD45, which is kind of thought of as the pan white cell marker, or they often don't express that, right? CD138 is a good stain for them, but also remember that CD138 stains squamous cells and a lot of epithelial tumors, so don't rely on that alone, of course. I know that you know this, Adam, but just for all the other people who are listening, so MUM1, MUM1 is another great marker, and I asked one of my heme colleagues who had a lot of myeloma experience, I said, if you just had one marker to screen for myeloma, what would you use? And they said they would actually use MUM1. But if I have a high suspicion, I'll often use both CD138 and MUM, and then you can go on to do kappa lambda and stuff. But this wasn't that. This was desmond positive, as you went to right away, and that is an excellent job. So if you had to then do anything else, any other stains you want after desmond positive?
Yeah, you need the more specific skeletal muscle markers, so like myogenin, MyoD1, look for nuclear expression.
Very good. Now let's see. This is the desmond. We can see here for the resonance, this is a piece of appendix used as control, and you can see the desmond strongly staining the muscle wall and the muscularis mucosae layers of the appendix. And then here, blazing expression of desmond. So that's what's making those little blobs are oftentimes, when you have those rhabdoid morphology, it means that there's a globule of intermediate filament that's filling up, and that's why it has that hard look. In a lot of tumors, it's keratin, like you said, proximal type epithelioid sarcomas, and malignant rhabdoid tumor, which may be on a close spectrum, have that rhabdoid appearance and are packed full of keratin. In this case, desmond was the intermediate filament filling up these cells. An extremely strong diffuse staining here. Then here's the myogenin, also known as MYF4. MYF4 it's a nuclear transcription factor related to skeletal muscle development, and it is going to be positive in the nuclei of rhabdomyosarcomas, and rarely anything else. Also, there's another stain called myod1, which serves a similar role and can be used as a marker. So a lot of times, depends on the type of rhabdomyosarcoma. A lot of times the staining for myogenin and myod1 will just be focal. So you can see it here, nice strong nuclear staining just in a subset of the tumor cells. And that's often the case, except for things like alveolar rhabdomyosarcoma, which is extremely rare in the skin, although we're working on a case report of one right now, actually. We're about ready to submit it. And those are like diffusely, all the cells will be positive. So yeah, this was an example of the kind of relatively newly described, I mean, not really new, but this entity called epithelioid rhabdomyosarcoma. Chris Fletcher has written about that, very famous, well-known soft tissue pathologist. So this was epithelioid rhabdomyosarcoma in the skin. And it seems like rhabdomyosarcomas are always thought of as pediatric tumors because they certainly are much more common in kids than adults, but definitely adults, even older adults, can occasionally get rhabdomyosarcomas of various types, and those can arise as primary tumors in the skin extremely rarely. Soon after I finished my fellowship at Emory, I co-authored a paper with Steve Billings and Trent Marburger and other colleagues where we put together a series of cutaneous rhabdomyosarcomas. I think we had 11 cases, and to my knowledge, that's still the largest series in the literature. So it's very, very rare, but it does happen. And because of that, and I've seen a few more cases in practice now since we wrote that paper, I include desmond on my initial screening when I have the AFX differential for malignant spindle cell tumors in the skin. I add in desmond, and I also do ERG or CD31 because I've seen rare cases of solid kind of spindly or epithelioid angiosarcoma that didn't have any obvious vascular channels. And those are very aggressive tumors that need to be potentially handled differently. And in this case, this poor patient, unfortunately, within 6 months of diagnosis, had lung metastases, multiple lung metastases. And I never did find out the final follow-up, but I suspect that he probably died from his disease very quickly afterwards. These can be very aggressive tumors. Some sarcomas, when they arise in the skin, tend to be better prognosis and more indolent. Rhabdomyosarcoma is not one of those. It still has the fully malignant potential when it's in the skin. So I do include desmond in my screening test, and if desmond's positive, I reflex to myogenin. I will point out for Adam and anyone else who's going to do Dermpath, I do from time to time see focal desmond expression in tumors that otherwise look and stain like AFX or pleomorphic dermal sarcoma. And usually I just kind of chalk that up to non-specific myofibroblastic differentiation. I will add myogenin just to be sure, but usually rhabdos are going to have a lot of desmond, not just focal. And I feel like if it's a pleomorphic ugly tumor and just focal desmond, to me, that's not enough to make it a leiomyosarcoma. So, but I guess that would be the other possibility. But I feel like ugly pleomorphic spindle cell leiomyosarcomas usually are big, deep, soft tissue tumors, not in the skin. In the skin, leiomyosarcoma usually looks like a smooth muscle tumor. Even when it's really ugly, it still retains that kind of pink cytoplasm fascicular growth pattern. So yeah, epithelioid, rhabdo, and a good discussion of the differential of rhabdoid and plasmacytoid tumors in the skin. Excellent work. All right, let's close those windows out here. Any questions so far? You guys are doing great. Hopefully these are of interest to you. It's hard when I'm giving a talk to a place like Emory, where you guys have incredible mentors who are skilled in Dermpath and soft tissue, and you get to see all sorts of cases. So I want to find stuff that's going to be of enough interest and value to you and not be like, yeah, we've seen that before. It's fine. Okay. Case 5, 50-year-old man with an ulcerated firm nodule on the shin. This one is so fun. I really like it. Anyone want to tell me what this is?
We had a tough time with this one. We thought maybe there's two things going on at the same time.
Very good.
Maybe something overlying a DF, but something malignant, but we weren't entirely sure what that malignant thing may be. Maybe something glandular.
So, I'm trying to turn my screen here. The little zoom window's in the way. There we go. This is great. So we'll leave the cancer for a minute. You're right. That's a cancer. It's a carcinoma. It's not quite as fascinating as you might think, but still, it's fascinating because of where it's growing. Here we got a nice example of dermatofibroma. Spindle cells, most of them bland, some a little bit bigger. This one has a nice kind of storiform pattern. We always talk about storiform pattern as being the key thing for dermatofibrosarcoma protuberans, but I see dermatofibromas with nice swirly, whirly storiform pattern all the time. And that's one of those times if you're having trouble and you can't see the fat underneath, you can always add a CD34 stain on for cases like this. Some people like factor 13A as a positive marker. CD34 will be negative in DF, although it's often positive at the periphery, but in the middle it'll be negative. DFSP will be strongly, diffusely 34 positive, almost the vast majority of times with rare exceptions. So in times where I can't see the fat and tell, or if I'm having trouble, especially on the ones that are like bland, spindly DFs with lots of swirly, whirly storiform, 34 can be really helpful. I find 34 much more helpful than factor 13A. I think factor 13A stains lots of stuff, really non-specific, and I just don't find it as useful. But I know a lot of really good dermatopathologists who like it, and that's cool, but I don't tend to use it for spindle cell tumors, really. Occasionally, I use it for sebaceous tumors if you have the right clone, but that's a different topic for another day. So what we have above the dermatofibroma is this blue stuff. So what is this? Anyone? What are you going to do with these blue basaloid stuff right over a DF?
Follicular follicular induction?
Yeah, exactly. This is the follicular induction phenomenon. Some dermatofibromas in general tend to exert this weird effect. I don't know cytokines or what causes it exactly. I just know what it looks like. It makes the epidermis grow. So what it often shows up as is this: elongation of the reedy ridges. Oftentimes they get flat at the bottom, or what we call tabling. This one's not really doing that. I guess, well, there's a little tabling over here, a little bit of flattening. And, my former fellow, Gina Johnson, who is another Emory alumnus, did her pathology residency there, she always said that these are tables and chairs. I'm not exactly sure what the chairs are, but I thought it was cute and I like that. So I always say these are the tables and chairs of Gina Johnson. In her honor, I like to name eponyms after my fellows. So if these will show up on boards down the road, then future generations of Derm and Path residents will hate me, but oh well, I don't care. So, and yeah, the other thing is that sometimes the epidermis doesn't only grow, but also we get growth of adnexal structures, particularly hair follicles. So this is like the germinative matrical cells that are growing, and then they begin to develop some outer root sheath features. So you get kind of basal palisading. You can get some glycogenation and clearing of the cytoplasm here like that. That's outer root sheath. And the way you tell that this is not a basal cell carcinoma, for one thing, anything that looks like a basal over a dermatofibroma, the answer is not basal cell carcinoma. The answer is benign follicular induction. That's the general rule that I teach, that if you think it's basal over a DF, it's probably not. It's probably induction. And this is a well-known phenomenon. The thing I find really helpful is this. See how the stroma, these rounded cells, they clump right up next to the basaloid nest and hug it, just like you see in the stroma of a hair follicle tumor, like a trichoepithelioma or a trichoblastoma. And you can even see little like papillary mesenchymal bodies sometimes, which is what this is kind of on its way to becoming, little rounded cells pushing into those basaloid nests. So that's really helpful to me. And usually there's not clefting and mucin like you'd see in a true basal cell. Sometimes you can get a little clefting, but usually there's more of the stroma hugging tightly against the stuff. But here's what's cool about this case. This is actually not anything fancy, although you're right, there are some things that look a little gland. Like this is just a kind of ugly basal cell carcinoma. But clearly this is not induction. This is truly a cancer here. And the palisading is a little vague, but you can see palisading in some areas and kind of a more mucin-rich stroma. And certainly cytologically, this tumor is malignant, even has a little bit of necrosis. So this was a very, very unusual example of an actual true basal cell carcinoma that's colliding with a dermatofibroma. And what I love about the case is that it breaks the rule that I always teach. And if you do Dermpath long enough, all the rules you teach will eventually get broken. This is true of all parts of pathology. But so I always say don't diagnose basal over DF, but I've seen a couple now that were true, or in my opinion, true basal cells over dermatofibromas. And in this one, I thought it was really fascinating because this tumor had actual not only basal cell carcinoma, but actually had really nice follicular induction. You could, here, this is one where you see this. This is actually like making a little hair papilla or papillary mesenchymal body, and is actually forming like an actual little well-formed hair root, see? And sometimes you can also see sebaceous gland growth, like sebaceous induction, either with the follicle or by itself. I've seen ones that, sometimes the derm residents will send in as like DF versus sebaceous neoplasm. And it's because it's a DF with lobules of sebaceous induction with hyperplasia. So I've seen that a handful of times. Pretty cool. So I kind of wonder if maybe did the basal induction go bad and turn into the basal cell carcinoma? Or is this just a pure coincidence? And I have no answer for that, but I just think it's so cool to be able to see this. What you guys were seeing that look kind of like glands is just the pseudoglandular pattern, or what sometimes people call the adenoid pattern of mucin forming little pools within the basal cell carcinoma. And basal cell carcinomas can run a really wide range of features, as I'm sure you all know. Sometimes they have relatively bland nuclear features. Other times they can be very ugly or even frankly pleomorphic, and it doesn't appear that the cytologic features of basal predict how it's going to behave. The real ugly ones don't like suddenly behave more aggressively. Obviously, the pattern of growth is what matters more. This is kind of more of a nodular pattern overall. So I would expect that this is going to end up actually having a good prognosis. I never did find follow-up in this case, and this was also from years ago, but I thought this was a pretty fun example. All right. Any questions? Here's another fun one, one that's not necessarily an ultra rare thing, but just a really awesome example. So here's the clinical. Ulcerated, fungating nodule coming off of the fourth toe. It's another angle to look at it. Nasty, I'm sure that really was bothersome to the patient. Definitely looks like a big polypoid thing that's, ulcerated on the surface. And then here's the path. All right. Let me hear from did any of the junior derm residents figure this out? I had 2 questions. One is, what's the diagnosis? And number 2 is, what's the bonus finding? Don't be shy.
We thought maybe pyogenic granuloma.
Very good. You thought correctly. This is like the biggest pyogenic granuloma, or lobular capillary hemangioma, as they're also called, PG. Like the biggest one I've ever seen, probably. It's huge, and it is nice that we get to see the whole thing with the whole base and everything, because this was taken off by a surgeon who removed it definitively. And I think, honestly, that was probably good for the patient, because they were able to get all the way under it and, to cauterize the vessels or tie them off to hopefully minimize the chance of recurrence. Because you can imagine a shave through this, that thing's going to grow right back probably. The lesion is pedunculated here and sits on a stalk. It's got kind of some feeder vessels coming up to it from below. And the lobular shape is not as easy to see in this one. Sometimes they have a very nicely lobular shape, but I think here you can kind of appreciate there's a lobule of capillaries around a central vessel. Here's a lobule. Here's kind of a lobular shape here. And I think that's really helpful in vascular tumors, that the lobularity often goes hand in hand with benign vascular processes. And infiltration sometimes means malignancy, although not always. There are plenty of examples of benign vascular things that have a kind of infiltrative growth. In the middle of a PG, it can look pretty busy. But when you see the whole thing out, or when you see the edges, it tends to look much more organized. You can see like this is the edge of the lesion here, and there is a little bit more extension down here, but even down here, look, it's a lobule, see? So that can be helpful. Now, enough from low power, but the low power really helps with these things. But let's go in closer, take a look. And what we see here are small vessels. They've got plump endothelial cells around them. There's a lot of cells in between the vessels. Many of these are going to be pericytes, which are actin positive modified smooth muscle cells that wrap around small vessels, okay? There can be variable amounts of hemorrhage and inflammation, although the inflammation tends to be more prominent near the ulcerated surface. If you start seeing a bunch of neutrophils down in the middle of something that looks like a PG, what other things should you think about? There's a rare thing that can mimic pyogenic granuloma, but tends to have more neutrophils.
Bacillary angiomatosis.
Very good. Bacillary angiomatosis tends to have a lot of neutrophils in it, and if I start seeing a bunch of neutrophils in the middle of a PG, I go looking around for those bacterial colonies, and I got a video on YouTube about that you can go check out if you need. Sometimes there's a lot of hemorrhage and fibrin around the vessels, and just like anytime you have a big ulcer, you can have the neutrophils coming out of the vessels can kind of give you a vasculitis-like appearance. So don't be surprised at that. And the vessel changes are similar to those we see in granulation tissue. And there's a lot of kind of overlap between what looks like granulation tissue and what's truly a pyogenic granuloma. Okay, so you guys know all that. This one has a ton of edema also. Pretty nice example because we got a nice clinical and the nice full path specimen. Oh, and one other thing I was going to point out, that especially in the ones that are ulcerated, I feel like you see it more, the endothelial cells can get pretty plump. I mean, look at those guys. They're big and juicy. They're plump. They have large nuclei. They look different than regular endothelial cells, and that's because they're actively growing and kind of probably have some reactive sort of changes related to the background inflammatory environment. And you can see mitoses. So large cells and mitotic activity is, to me, a normal feature of pyogenic granulomas. I don't get real worried about those. If I start seeing like pleomorphism and really hyperchromatic nuclei, I might stop and give some thought to that. I'll tell you, I will stop and give some thought to that. And if I'm really concerned and I don't see the base of the lesion, then there are occasional times if I'm not really sure, or if the clinical scenario is not quite right, that I'll either say watch it closely, and if it comes back, completely excise it, or I'll have them go back and take more. That's the general rule I use for vascular things. If I've got any doubt, number one, consider getting a consult. You can try stains, although a lot of times, like the diagnosis of angiosarcoma, there's not a lot of stains that help you except maybe CMYC in the setting of post-radiation. But outside of that, you oftentimes are really kind of left with looking at the pattern and the cytologic features. So that, which is kind of frustrating, right? Vascular tumors are really fascinating, but there are a fair number of times you're left with making a big decision between benign and malignant based on the pattern without a lot of ancillary help. And so in any case, when I have a doubt, what I recommend is close follow-up, because usually an angiosarcoma is going to show itself very quickly. They're often very quickly, rapidly growing tumors, not always, but a lot of times they are. And so, with follow-up, if you end up being wrong, hopefully that can be detected as soon as possible so that the patient can get the right treatment quickly. Okay. Before we go to the bonus finding, let me show you the immunostains on this case, because for teaching purposes, I did immunostains here. I don't think we needed that for the diagnosis, but we just did them at no charge later for teaching. Where are they? Oh, I already opened them. So this is an example of CD31, which is an endothelial marker. And you can see what it can help with is in cases where you have a very busy vascular lesion, or where a very cellular vascular lesion. Sometimes the vessels get so packed closely together in some vascular lesions that it's hard to see the lumens. And so it can look more like a solid sheet of cells. This one was not so much that way, but sometimes that can happen, and it can be very hard to tell like what the actual pattern of the vessels is. And I find that doing CD31, you can do ERG, although this is a time that I like CD31 better because it's a cytoplasmic and membranous stain rather than nuclear, so it tends to give you these nice sharp lines around each vessel. And look at that, isn't that beautiful? You can see every single vessel space, even these small ones, tiny vessel, tiny vessel, tiny vessel. Each of these little things, you get these little tiny vessels, and they're nice and well formed, and you can see much more clearly here. Look at the lobular pattern there. It really enhances and highlights that pattern. Again, with practice, you can usually do this on H&E, but I've definitely found it helpful in certain cases that the CD31 stain can really highlight that pattern and make it a little easier to visualize. And also, if we go down lower towards the stalk, you can see here that the lesion really does end there. There's a little lobule here, and then down here there's a background dermal blood vessels that are kind of an increased reactive number of them because of this inflamed ulcerated surface, and surely they're recruiting some new vessel growth here. The one other thing I take that back. This is not CD31. This is CD34, but it serves the same purpose. The reason how did I know this was CD34?
Staining some like fibroblasts in there.
Yeah, the normal dermis stains strongly with CD34. Okay, that's why it's helpful in DF, because the background dermis will be positive. It'll be brighter at the edge of the DF, and in the middle of the DF, it's wiped out. The same is true often in scar. So this is a lot of this stuff here is probably scar tissue kind of growing around, because in scar tissue, you're getting granulation tissue comes in and replaces what used to be dermis, and then as it matures, it turns into scar, and those dermal dendritic cells and fibroblastic type cells, I think there's some sort of dendrocyte. I don't have a full deep understanding of dendritic dermal cells, but they're CD34 positive dermal dendritic cells that populate the dermis, and when you cut out part of the dermis and then it fills in with scar, it takes a while to get repopulated by those cells. So 34 is not a specific marker for vessels, and in the setting of angiosarcoma, it can occasionally be lost, but there are certain times it helps. It's really good in Kaposi sarcoma, because Kaposi sometimes lose CD31. The HHV8 virus can cause downregulation of the CD31 molecule. The other thing is in CD31 will stain histiocytes, also kind of a grainy, grungy stain. CD34 doesn't do that. So in this lesion here, there's like very little background. So the CD34 is quite clean in this lesion that has a background that's not normal dermis. But when you're looking at normal dermis in the background, CD34 can be pretty dirty and hard to interpret. So you can use different markers for different things. Okay, so that was more one for the people that are going into Dermpath, and for the derm residents, I'm sorry, you probably won't need that for your real world. But I will also show you, I did as a flip side, the actin stain, and actin to stain the pericytes. And oftentimes you get pericyte layer surrounding the vessels. This one was a little weak, and it's not quite as pretty. I guess I should have checked it before I uploaded. But it can kind of help you because it gives you the negative image of what you saw in the CD31. All the background cells in between the little vessels, those are actin positive. And usually benign vascular things have a nice layer of actin positive pericytes surrounding each of the vessels. Angiosarcomas sometimes lose that, although not always. Dr. Weiss taught me this trick about that in cellular things you can use a vascular marker plus actin to kind of see which cells are pericytes and background myofibroblasts and which cells are endothelial. And it does work sometimes, but I've definitely seen times where there were exceptions to the rule. So it doesn't always work, but it can kind of help you out in a pinch when you're dealing with a challenging case and you need to get a better feel for the pattern. But here I just thought it was nice for teaching. Now, did anyone find, you can tell I like this case because I beat that to death, but did anyone find out what the bonus finding is? Then I said it is near the base of the lesion. Did anyone see it? It's pretty subtle.
Are there some nucleated red cells down there?
There you go. It's cool because you can see them even from low power. You can see this dark little areas there. And when we go close, you can see these guys here. They are round and super hyperchromatic, really dark, almost as like they're dark like lymphocytes, but as opposed to lymphocytes, they're even more perfectly round, and they're little tiny ones, medium ones, and bigger ones. And I find that feature, like perfectly round, really dark cells, kind of like lymphs, but of varying size, clustered together, erythrocyte precursors. These are bone marrow elements, basically, that are arising here. And over here, there's some more of them, and also, oops, a little bit too far. More of the erythrocyte precursors, and these cells right here I think are probably myeloid precursors, so developing neutrophils basically, and you can see their chromatin is a little bit different. So this is basically what we see in bone marrow, so when it occurs out of the bone marrow we call that extramedullary hematopoiesis, and it's a thing that can be seen occasionally in the skin. I have to tell you though, it's extremely rare, or at least I've only recognized it rarely, and the couple times I've seen it, this is the second case that I actually saw little foci of it in the middle of a PG. So I don't know what's going on, if the PG is releasing some cytokine factor or something that's recruiting these cells there, but I've seen it 2 times in PG, and I actually don't think I've ever seen an example of it otherwise in the skin. It's definitely well described, but it's something that I've rarely ever encountered, but I've seen it twice in pyogenic granulomas, excuse me. I have to always check myself to not mix up the 2 PGs in name when I'm talking about it. So I thought that was pretty fun. Okay, in our last few minutes, let's do the last 2 cases. Okay, so a subq nodule on the scalp of a 5-year-old boy. And you can see it's a subcutaneous circumscribed nodule. It's got a dot on it. Sorry, should have wiped that off before I scanned the slide. It's very pink because it's rich in collagen. It's composed of collagen. There are some small vessels, tiny bit of mucin here and there, some little cracks between the collagen, and really very little cellularity, right? There's some bland fibroblasts here, maybe a scattering of lymphocytes, but there's really like not much here. It's like a ball of collagen with some sparse fibroblasts. Did anyone figure out what this is?
Gardner fibroma.
Very good. And that's what this is. This is a Gardner fibroma. It's basically a hypocellular ball of collagen, usually in the subcutis. It's often midline back or neck, sometimes other sites. Again, this one was a scalp, but the key is it's a child, okay? They don't really have much specific look. Sometimes they entrap fat, they can entrap nerves and stuff, but I find that really when I see a hypocellular sclerotic nodule of collagen in a kid, Gardner fibroma is a thing that we got to make sure that we exclude. If there's any doubt, then they need to do workup because, you know, this may be the presenting sign that's seen before we know that the patient has Gardner syndrome, familial adenomatous polyposis. So if in doubt, I would want them to get the kid to a genetic counselor to work up. I hate to give people excess worry, but I would hate even more to miss it and have the kid end up getting colon cancer or something because they had a late diagnosis. These are supposed to be positive for nuclear beta-catenin, and in fact, there have been some descriptions that some of these can actually turn into desmoid fibromatosis. I've never seen an example of that, but it's well described in the literature. They can be like a precursor lesion to desmoid tumors. And beta-catenin is a challenging stain to get to work. Technically, it has a lot of background cytoplasmic staining, so I tend to not use it very often, but it can be helpful in supporting this diagnosis further. You'll have nuclear staining for beta-catenin. Okay, but before we talk more, I'm going to go to the next case because it kind of has a similarity. This is a 30-year-old diabetic man with a subcutaneous nodule on the posterior neck. And I use both these cases because it's the rare time that you actually see a nice, perfect excision that you can see the entire lesion. And here again, it's a nodule in the subcutis, composed of dense collagen. This one's a little bit different than the last one because that last one had a little myxoid change. Also, the H&E stain on this particular example has a little different hue, but it's kind of the same concept, right? Ball of dense collagen with the kind of cracking artifact in the subcutis, bland, spindled fibroblasts. The only real difference is this is in like an adult. And there's some entrapment of fat down here. You can see there's a little bit of trapping of fat there at the edge. So what would this one be? Anyone?
Just a nuchal fibroma.
Very good. This is nuchal type fibroma. We used to say nuchal fibroma, but now they say nuchal type because you can see very similar lesions to this that are away from the neck. But this one's nice because it was actually right there on that posterior neck near the hairline, as you can tell from the thing. So to me, I've written like a chapter about Gardner fibroma before. I feel like the very best way to sort these out is the age, okay? Nuchal type fibromas occur in young to middle-aged adults, and Gardner fibromas occur almost always in kids. Because, by the time someone's 30, if they have Gardner syndrome, probably we're going to know by then, right? Because they're going to have polyps, and they will, if they've not been treated, they will potentially have progressed to colon cancer by that point. But I feel there are some subtle things, like sometimes you can see a little proliferation of nerves in one, but not the other. I feel like, though, from I've not seen many cases of either of these. They're relatively uncommon. I feel like, to me, the most helpful thing is if the beta-catenin works, that would be helpful, but I find the age to be the most helpful thing. A nodule of dense collagen in the dermis with low spindle cells. In a kid, I'm going to think Gardner fibroma. In an adult, I'm going to think nuchal type fibroma as my main differential. So these are two examples of those back to back, because I feel like I have like a template I use in my reports that basically says, I think it's this, I think it's nuchal type fibroma. Gardner fibroma can look similarly, but usually presents in kids, or I swap that around in the setting of kids. So that's kind of the way I handle these, is that I often usually mention both of them in my report, but say based on the age, I think it's this, or if needed, you can use beta-catenin too, depending. So that's how I approach Gardner fibroma versus nuchal type fibroma. Okay, and that brings us to the end of our cases. Are there any questions?
Dr. Garner, you did a SMA on that pyogenic granuloma for education, but just hypothetically for vascular lesions, how much utility do you find in terms of looking for loss of pericytic expression in malignant vascular tumors in equivocal cases? Is that something you found diagnostically useful?
Well, that's a good question. So when do I find actin helpful in the setting of angiosarc versus other? So, I found it to be less helpful than I hoped it would be, after Dr. Weiss told me about it. And I think it's something she only rarely would do. But I've tried it out, and I actually had started trying it for teaching on a handful of different vascular things. So I took some angiosarcs and some hemangioendotheliomas. And the results were not quite as good as I hoped. There were things that I knew were angiosarcoma, either from the overall features or their behavior, that still had some actin-positive cells around the vessels, much more than I thought they would. And there were also times where benign things that clearly had a benign behavior had some loss, or it was difficult to see the pericytes. So I actually had started making stains because I was going to make a video about it, and I abandoned the project in the middle. Now, maybe I just didn't stain enough, but I went through a handful of cases, and I was like, this is not really going to be as clear as I had hoped it would be for the purposes of making a video. So it's something that I've experimented with a little bit to try to get a better handle on, but I have not found it to be a perfect solution in borderline and difficult vascular cases. I still will do it sometimes, but definitely I think take the findings with a grain of salt, because it does not seem to work as like a perfect, cut and dry answer to telling you if something's malignant or not. So that's been my experience with that.
Awesome. Thank you.
You're welcome. Thank you guys so much. You did a great job. You answered all the right answers, and also brought up some of the answers that I was hoping that people would bring up so that we could have a good discussion about pitfalls. And it's a great honor to get to be back at Emory, even though it's virtually. But it's great to talk to you guys, and I hope you'll stay in touch and keep up with me online. And thank you guys very much again for the invitation.
Thank you.
All right. Have a great day.
Thank you.